Here's the standing lateral pelvis. We can see our anterior pelvic plane here and the rest of our spinal parameters drawn out. And we go to our seated flexion x-ray, and we can see there's pretty significant change in his anterior pelvic plane, and this is highlighted in our stand to seated number of 23 degrees. So he has a significant amount of pelvic mobility when he moves. And this cues me into the fact that he has a very tight, safe zone. So I want to make sure I increase his bearing size to give him the greatest amount of impingement-free range of motion. The next I'll look at is for him on the advanced tab. I can see his entire limb length, and it does show that his right leg is about 5 millimeters longer than his left, which fits with what I saw clinically. And I'll come to the stem. I'll sink the stem a few millimeters until I start to contact the calcar on the sides of the stem, which allows me to sink it a little bit more before I start to impact the calcar. So here now we've shortened him a few millimeters, which was our goal. And we haven't really messed with his offset, so our soft tissue tension should still be adequate. I'm ensuring that the cup is tucked under the anterior wall. I'll be able to remove that anterior osteophyte intraoperatively and the posterior osteophyte if needed. And I want to make sure that my cup isn't retroverted when he goes into seated flexion, as he does have pretty significant pelvic mobility. So I'll antivert this cup a little bit more until I get usually over 5 degrees on my seated version of the cup, and making sure that I'm not going to impinge posteriorly. So that looks pretty good. And we'll come back into extension. We can see I still have some room. I'm getting close, so I'm going to go dial a degree out. And we should be safe for this patient, coupled with his femoral anteversion. So here we are in the OR with patient MP. We've got our setup here for our anterior approach. We're on a table. We're using an Omni retracting system. The navigation part is here opposite us, our normal C-arm setup with the C-arm coming from the opposite side of the patient. We've got our socket cleaned up. We're going to start the reaming. First, make sure we've got a good x-ray. So here on the left, we have our navigation screen, and then on the right is our normal C-arm setup. So we're using this on the left side as my goal. And now I'm going to use this as my template, my trial cup, to get the correct version. Shot. We're getting close. So our anterior wall is feeling as we expected. Okay, so here's our goal. So we medialized as we thought. We are a touch higher than we planned, and our version looks good there. We're a little bit more vertical, which we can fix on our next shot, but I'm kind of using that as muscle memory. I'll get this into place. Sweeping all the soft tissue out of the way. And we'll ensure we're tucked just as we expected on our plan under the anterior wall. We've got lateral cup exposed. Shot. So send that over. We're a touch flat saddle punch. So we can do some micro motion adjustment or micro adjustments here. Shot. We'll work this approach a little bit. We know we're trying to shorten him, so we have to sink it. Fair amount. Okay. Okay, let's take the trial. So now we'll take our shot and send it over. Okay, so we've got our floor image we're happy with. We're going to send that over and see how we did on the leg length and offset. So we know we wanted to shorten him, so it should look short. So here's where we are with our plan. So our offset is pretty much unchanged. Our length has not changed by much. I'll double check this just to kind of reinforce it. And yeah, we are short on the overlay, which is what we expected. Take our final x-ray, make sure there's no fractures. Okay,
Save that. And you can send that over for our last check too. Okay, you can come up and out, Phil, when you're done too.